afraid of you. Ingrid, I'm afraid what you're going to do. What a way to start a treatment. Can you imagine starting with someone saying, I'm afraid of you? Then I'd have to say, look, no worries. You're going to tell me your story. You're going to tell me what everything's about. And then we're going to come up with a plan that's right for you as an individual. Cardiovascular issues is the main um, risk for death for women. We hear about breast cancer, and it's not that we shouldn't talk about it, don't get me wrong, but we don't talk about cardiovascular health. So it really means our whole medical system needs to be much more aware of these conditions earlier.
Welcome to the Femtech Health Podcast. Today, we're excited to have Ingrid Harm-Ernandes with us. Ingrid is a renowned physical therapist who has dedicated nearly 20 years to women's health at Duke University, where she served as the co-director and mentor for the Women's Health PT Residency program. She is also an international speaker, author, and illustrator, with a deep passion for pelvic health. In this episode, we'll explore Ingrid's journey into the specialty of pelvic health, the evolution of education and resources available for pelvic PTs, and the critical need for collaboration among healthcare providers. You'll learn about the importance of mentorship, the continuum of care for women throughout their lives, and the pressing issues surrounding menopause and pelvic health. All right, let's dive into today's show.
I'm here today with Ingrid Harm-Ernandes. She is a physical therapist at Duke University, or I should say she was a physical therapist at Duke University for almost 20 years. She was the co-director, the mentor for Women's Health PT Residency program. She was the course development director as well. She is also an international speaker, an author, and an illustrator. Thank you so much for being with us today. It's so exciting to see somebody who's had such a long history in women's healthcare, and especially, for such a specialty as pelvic healthcare, et cetera. All of this is such an advancing, development of care, and we're just excited to have you. Tell us how you got kind of involved in this specialty. That's a long time to be so dedicated to this particular type of work.
Oh, well, first, thanks for having me. And I love talking about pelvic PT, as you know from when we've talked. But I would say so when I started as a PT, there was no such thing as pelvic health, women's health. So, just over a couple years time, so I've been a PT for 40 years and a pelvic PT for about 28,
Mhm.
29 years. So it's kind of like when I started, where do you go? And there were some courses I could take here and there. In Australia, they were doing things, and over in Europe, they were doing things, but not so much in the United States. So I think when I first
Mm.
started and I would tell doctors and nurses, I can do this, I can help your patients with incontinence or whatever it may be, they looked at me like I had lobsters crawling out of my ears. They just thought, what are you talking about? But once I convinced them, hey, send a patient, and the patient's like, why did you not send me earlier? Then all of a sudden the doctors and the nurses were on board. So it was a nice change, but it was still, I would say, a really, really slow growth. And I am ever so grateful that I was orthopedic first because I use all those skills with my pelvic health skills that I gained over the years that I learned not only through our courses that we can take, but from my patients, right? That orthopedic skill is so, so important in progressing it. And now through residency programs and educational resources and so forth, there is a lot more that's available for pelvic PTs to really grow. So I'm very happy to see those changes and that is improving, but I still think we have a bit to go.
It'd be just because we're talking a little bit about this residency program, I brought it up. I mean, there's not that many residency programs in the US, correct?
There are not. They're not. They're slowly growing as well. So Duke was the first one to have a residency program. So it was truly,
Mhm.
truly a really new thing. I
Mhm.
mean, we were learning as we were going, which was awesome. I mean, it was great to see the progression and that there are more programs, but I don't think there's near enough. And there's not enough education within PT programs as it is. I mean, I go do book clubs for some PT programs, where, I talk about my book and we go over things, and then we go over like the experience clinically and how does that relate to pelvic health and so forth. And it's great to see how excited they are, but there just isn't enough within the school, not just for PTs, but nurses and doctors and so forth. I think that's another area we have a long way to go, is to really try to get that education earlier, so it becomes a more normal thing to address and to help people with.
Ingrid, you mentioned just really quickly that you were, orthopedic therapist before, that you walked into this world. Share a little bit of that, because I think it's important for, some of our younger, newer grads coming out. They do get nervous to kind of walk into pelvic health so quickly and not maybe have some background. And yet, if they already know that they really want to hyper focus on pelvic health, how can we help this transition time? Maybe they don't have a chance, to actually, go to a residency program, but how do we help them when they already know they want to do this work specifically, but maybe they don't have the depth of knowledge in that? Talk about that a little bit with us.
Yeah, so I would say, so a big hallmark of a residency program is mentorship, but that's not the only place we can find mentorship. So I think for someone who's, well, maybe they're interested, but they're not sure. Maybe they got a tiny little bit in their program, and now they're like, well, that's interesting, but I'm not sure. So I always say to all the students when I'm at CSM and we're just talking, I can see they're so tense about, I have to jump into a residency program. I have to do this. I'm like, no, it's fine. It's okay if you get out there and you're a generalist, right? Because you learn so much. And when you're out there, all of a sudden things become a little more clear. When you feel a little more settled as being a PT, the world
Mhm.
becomes a little more clear, I'll say. And all of a sudden it's like, oh, yes, this is what I want to do. Then the next step would be shadow. Please reach out to a pelvic PT, someone who does that kind of work, and just say, can I spend a day or so with you? Can I just see what you do? Because I think that convinces people, do I want to take that path or don't I? Because as much as I'd love to see, and I'm sure you would too, more pelvic PTs, we don't want someone who's not comfortable doing it trying to do it, because it will not only be difficult for the PT, the patients will know it too, right? So I think find your passion by being exposed to it. Go talk to a OBGYN, a urogynecologist, someone who refers to pelvic PT. What is their perspective, right? So that mentorship isn't just a pelvic PT. It can be outside of, or in fact, I highly encourage going outside and talking to those other physicians and nurses and PAs who all touch our field and work as a team. Right. So teamwork is something I'm always on my
Mhm.
high horse about. And that includes that mentorship. So I always say, please. So when we have our residents, our pelvic PT residents, I say to them, I would like you to spend time with the orthopedic PT, the cardiopulmonary PT, the OBGYN, the urogyn, the acupuncturist, the sex therapist, so that
Mhm.
mentorship goes with trying to encourage the team very, very early in the career to realize they're not alone. Because I would say my experience, I didn't have the opportunity for mentorship because it wasn't there. There, we were, those who started were, you know, a dozen or so across the country. And when you finally started talking to each other, you're like, cool, that's what I do. But I find that now the mentorship is there. Now I still speak to my former residents. I still reach out and we still have conversations and communicate on things. And it's just so lovely to know that that mentorship never stops. It's always there. So I would say form those bonds early and then keep reaching back and build your team. Build that mentorship team as well as a treatment team.
Thank you so much for sharing that. And I love this idea that, we're sort of thinking outside the box too, of like, we're not just integrating with other pelvic health therapists. We are talking to every different kind of provider in our geographical region, right? Because we are not doing women's health alone. I mean, this is the thing I think that really has hit home for me just in our region in the Pacific Northwest. We are in relationship with every different type of healthcare provider that there is, right? Because we can't take care of women well. Do you know what I mean? Being in a silo alone of only pelvic health, we can only do justice for women's health when we're working as a collaborative team with everybody, right? I mean, whether it's the GI physicians, whether it's the OBGYNs, whether it's like you just brought up the acupuncturists, our nurse practitioner teams, like all of us are going to integrate together to give this woman the best experience that she can have, right? In women's health.
Yeah, it's one of the reasons I have to say it's one of the reasons that I wrote the book is because I feel like I wanted everybody on the same page. I wanted everybody to talk the same language. I wanted everybody to be able to say, "Oh, I understand what you're saying. What can I learn from you? What can I give you?" Right? So it's the sharing back and forth that helps our patient. What that's the bottom line, of course, is what gets our patient better the fastest and the best way possible. So I can't talk enough about that cross spectrum of in fact, I've probably done more education in the last couple years to everybody outside of PT, right? Whether it's the North Carolina Psychiatric Association or, a group that does interdisciplinary care and menopause care. Of course, that's a big topic that I think as pelvic PTs, we need to almost change a little bit of the
Yeah.
focus of that topic. But
Yeah.
but I would say that just being able to have that team, it just feels like I know I can help my patient instead of feeling I've got to do it by myself. It really, the feeling should never be I've got to do it myself. It should honestly be who can I reach out to on my team to make it better? Right.
So Ingrid, just because you brought up the book, I wanted to brag a little bit. So will you just tell everybody the name of the book and tell them where it came out of, like in your heart and your passion? Because I think it's so powerful. When something's been laid on your heart that you need to do, you just do it, and you're that kind of person. So tell everybody about the book, where it came out of, and why it really struck a chord that you needed to do this.
Well, so the book, I would say, was in my brain for many, many years, and so many people kept saying, "Ingrid, write a book. Ingrid, write a book. Ingrid," and I'm like, "Oh, I can't, I can't." What happened is at one point, I always recommended Desert Harvest products, and the CEO said to me, "Why don't you write that book?" She was almost like upset with me for not doing it. So she kind of gave me the kick in the butt, and so over the pandemic um, during the world of craziness, I sat there and I wrote this whole outline out in like a day and I sent it back to her and she goes, "How'd you do that?" I'm like, "Because it's been here. It just wanted to spill out." And so I would say one of the main reasons it was so wanting to pop out of me is because my patients are coming in referred to me with 5, 10, 30 plus years of symptoms and no one knew how to get them to pelvic PT or that it even existed. So I thought to myself, what is the actual issue here? Why is it taking so long? And I really delved deep in thinking over the years, what did I experience? Why am I seeing this? And it was because there wasn't education. There wasn't education for the patient, and there wasn't education for the other practitioners. So what was kind of upsetting to me is on both ends, there was a block to getting patients to where they should be. And I thought, well, how am I going to change that? How will I do this? Besides the lectures and the presentations I've done, there's got to be another way. And the book really was that way. So I wrote the book with an understanding that I want to make sure that it doesn't matter who's reading it, everybody can understand it. So lay people can understand it. Practitioners can understand it no matter where they come from because the language is such that this is what it is, this is what it does, this is what it means, this is how it connects to a diagnosis or a condition. So that when someone's reading it, they're like, "Oh my word, I didn't realize that the muscles of my pelvic floor, my core, my entire body can contribute, my mental health can contribute." So it's written from the perspective of putting all the pieces of the puzzle together, which is why it's called the musculoskeletal mystery. Well, I should say that again. A musculoskeletal mystery: how to solve your pelvic floor symptoms, because it is a mystery for so many people, right? So, not that it's a mystery novel, but I'm trying to resolve this mystery of why do these things happen and what can you do about it? I even wrote an entire chapter on what an evaluation looks like, an entire chapter on what treatment looks like. And a lot of that is because I had patients come into me and say, Ingrid, I'm afraid of you. Ingrid, I'm afraid what you're going to do. What a way to start a treatment. Can you imagine starting with someone saying, I'm afraid of you? Then I'd have to say, look, no worries. We're going to sit and we're going to talk for a long time. And you're going to tell me your story. You're going to tell me what everything's about. And then we're going to come up with a plan that's right for you as an individual. So that's also why I wrote that in the book, because you can see many different treatment plans. We all have different lenses. We all have different ways of looking at things, but they're basic. I would say they're basic things that we do as pelvic PTs. And then there's a section of self help in the back because some people are like, well, I don't even know where to start. I can't get to PT for 8 weeks. What do I do? How do I understand that better? So when I go in, I feel very calm and very reassured that I'm in the right place. I'm doing the right thing, and now my practitioner can really help me focus. Right. So it's many, many, many different levels. I wanted it affordable. I wanted everybody to be able to say, I can put this, in my back pocket, so to speak. And if I go to a doctor, I can open the book up and say, look, it's in here, and I really want this help. It legitimizes their conversation, right? It normalizes the conversation, but not the problem. These problems are common; they're not normal, but we don't normalize the conversation, right? And that's really where the book comes from. Like from my heart is, I don't want people to feel like they're alone. I don't want them to feel like they're suffering. I want them to feel like there's something out there for me that can really, really help me, right? So that was kind of where that came from.
I
Uh,
love it, and I think in the stuff that we're seeing now is that, people know there's a problem, right? But if we're not educating and teaching like all the providers and all of the different avenues, they don't even know where to go to look to talk to who they need to talk to. They don't know what they don't know, right? And so I think the more we have information like this that's coming from, people like you in a scientific way, do you know what I mean? Your background is deep in this work and that people can trust that. I think that's what's happening right now is to figure out like, oh, and then being able to take that to a provider and actually present that is very powerful because that's what we're seeing in the work that we're doing right now too, is that they don't even know. They know something's wrong, but they don't even know what it is to know who to talk to who to work with, how do I make a point with who? They get lost in that when they have this. And the other thing I want to bring up, and I think this is really powerful, is that you're looking at people globally because you know that pelvic health care is a global musculoskeletal issue. And I want to reiterate that over and over again, I think, with people because, people think they're coming into pelvic health or women's health and we're looking at this small region of their body, right? And that's all we're going to focus on. And that is not what this is. We are looking at overall global health to say, hey, you don't feel well. You know, if you don't feel well, then there's something going on, and we need to hunt, like you say, and solve the mystery, right? Till we get
Right.
to the bottom of what it is that a woman needs. And I think this is the perfect segue to the next thing that you and I are so passionate about, which I think is, looking at the continuum of life where we're looking at women as they pass through reproductive years, right? Their reproductive years are over. Now they're in this next stage of life that's happening. And I think we are spending a lot of time of our life as women in this next stage of life. And we
Yes.
deserve to have health care that answers this next stage of life. And when you look at, alone in the US right now, there's 75 million women who are in perimenopause, menopause. 6,000 women a day go into menopause,
Yes.
6,000 a day, right? It says by 2025, 1.1 billion women in the world will be in menopause. And yet we really don't have a lot of understanding and depth of how we're going to care for women in this continuum of their life when they've passed through their reproductive years. So, Ingrid, just talk a little bit about this other part that you are so passionate about because I think it's such a powerful time frame. I mean, women are coming into their own in a lot of ways. They have money, they have time because their kids aren't babies anymore, right? And yet they don't physically feel well. So, what are we doing?
Oh my, it's a loaded topic. So I look at, I guess I've coined this phrase, a continuum of life, just because I feel like we talk about like menopause, like it's something like way, way over here. And we talk about pregnancy, like it's way, way over here. And we don't realize how long of our lives we spend in this kind of this continuum where things are not
Mhm,
necessarily one phase or another phase or another. It's a slow up and down change that goes in one direction. And the reason why I say that is,
mhm,
data show that a woman spends about 40% of her life in post menopause. And I
mhm,
want to say post menopause.
mhm,
That means if
mhm,
perimenopause or the menopause transition, as we're hearing now in literature, is another 10 or more years, we're talking over 50% of a woman's life is in this
mhm,
menopause transition to menopause. And yet we hardly talk
mhm,
about it. Or what we do is we talk about hot
mhm, mhm,
flashes, right? We maybe talk a little bit about brain fog. We maybe, there's some other things we do. But what we don't talk about is pelvic floor health, cardiovascular health. Cardiovascular issues is the main
mhm,
um, risk for death for women. We hear about breast
mhm,
cancer, and it's not that we shouldn't talk about it, don't get me wrong, but we don't talk about cardiovascular health. And as a woman goes through menopause
mhm,
transition and into menopause, that risk goes up exponentially, right? Bone
mhm,
health,
mhm,
all of these things are what we should be talking about. And I think if we think, well, these days, women are having babies later in their life. So what happens is they go through fourth trimester, not postpartum. Fourth trimester is a lot longer. It's not the 6 weeks. It's not, hey, honey, go on with your life. It's rather you're still having symptoms, whether they be incontinence or prolapse or whatever it may be, for sometimes weeks, months, and years afterwards. Now, because babies are being born later, women are having babies later in their life, we go into the menopause transition right away and then into menopause. So there's
mhm.
never a halt of different kinds of symptoms, but we don't link them together. And the reason why I think, and I bring this up, is because younger in our lives, we should be saying to women, look, when you get pregnant, it's not okay that you have back pain, you have incontinence, you have prolapse after birth. It's not okay for these things. Let's address them now. Let's prevent a problem as we get later in life. Let's encourage women to, let's say, do more strength training, not all cardio. Cardio has its place, but women for decades have been taught, go run, run, go on the treadmill, do this cardio. They were not taught about strength training. What does it mean to do resistance training? How does that help our bone health, our cardiovascular health, our pelvic floor health? How is our pelvic floor integrated into this? Let's have conversations
Mhm.
about it and not be shy about talking about incontinence and constipation and prolapse and pelvic pain and pain with sex. And I mean, I could go on, right? You and I know that this is a huge, huge part of it. But in this continuum of life, if we catch things earlier, and you probably feel the same. If I could get every 18-year-old in a PT clinic just to discuss what pelvic health is, I would love to do that. I think we could prevent things later on, right? But right now that's not happening. So let's at least talk to women as they're preparing to get pregnant or they're going through that phase. So that as they get to the next phase in their life, they're ready. They understand they can help themselves. They're doing the right things earlier rather than later. So I think that that's,
Mhm.
the soapbox I get on with the continuum of life is, let's look at it as something we can take care of along the way instead of waiting until we're in trouble.
Ingrid, I so relate to this because I think, I started into that stage of my own life and it was pretty stressful, and no one was really talking about, hey, maybe some of these correlated with the fact that I was having that perimenopause or that early transitioning, and it started with thyroid cancer. So, and suddenly your body's sort of tumbling in a way, and you're thinking, wait a minute, I'm not really old enough to be menopausal yet, right? So no one's looking at you from the standpoint of like, hey, these things are starting to change. I was 48, 49 years old, and all of a sudden, having all these thyroid health issues that, who's talking about that, right? And so suddenly there's this great tumble that happens. And, for a good year and a half, I was really, really sick, with all those things that kind of fall along with those things, right? And I think looking back at it now, from what I know now compared to what I knew then, I realized that probably I was actually starting that whole transitioning process. I was walking into that transitional time frame, but with no direction, no education, no real confidence. Do you know what I mean? About, hey, what should I be doing and what should I not be doing? And I think that's the place that we're at now, you and I in our conversations, right? Is like, hey, we have got to stop this, cycle of where people don't realize, like, hey, we're all going to do it a little different. We're all going to transition at different time frames, et cetera. But if a woman doesn't feel good, healthcare providers, you need to be listening to her if suddenly she doesn't feel well. And don't tell her to go take, some pill or some whatever and send her out the door without doing the work to figure out, oh, I wonder where she is. I wonder how we should support her. I wonder what other things that we should be circling around with. You brought up some great comments of, cardiovascular health, bone health. Do you know what I mean? In those transitional time frames, we like need support, and whether it's PT support or all of our other providers, but it's really a difficult time frame for a woman. And if she doesn't have any support system or anybody who's educated to know how to lead her right into that continuum of care, it's happening. And now it's going to be 50% of her life. And think of it, she wants to give up. She's like, oh, this is too much for me. Like, I can't do all this because I don't have the support system set up, whether it be from a medical standpoint or whether it be from our home life or our community, right?
Yep, yeah, it's such a time that, you talked about the whole body before, right? It's the whole body, so that's why we need the team. That's why, someone will go, and if they're just told, "Well, oh, just live with it." It's something that happens. They don't have the bandwidth themselves to keep going to one after another practitioners and someone until someone answers their questions. So it really means our whole medical system needs to be much more aware of these conditions earlier. And there are some great organizations out there that are now starting to teach and give certifications for perimenopause and menopause. And I'm glad to see that there is something out there that actually someone can become certified in treating that because it is so needed. But even if you're not certified, I think the general population, I just did a whole webinar for all PTs on the musculoskeletal syndrome of menopause. And I really wanted it
Mhm.
known that this is for all PTs. This is not for pelvic PTs because all PTs, we are the movement specialists, right? That's PTs.
Mhm.
We deal with the musculoskeletal system. And to say things like, do you know that during this time frame, something like adhesive capsulitis, the risk increases
Mhm.
dramatically during the menopause transition, right? That's just one example of what happens. So if as PTs we don't realize, oh, we have a patient who suddenly comes in and has a frozen shoulder, well, are there other things going on that we need to be aware of that maybe
Yeah.
treatment-wise would be helpful? Right? So that's what I'm saying. Everybody needs to know, yes, I want the specialist, but everybody needs to have at least some foundational information on how to treat someone going through the menopause transition and menopause.
Mhm. Absolutely, and I think it reaches outside of just our own physical therapy organizations, right? Or like our thought processes into all the different areas, right, of healthcare. Whether it's mental health care, whether it's our primary care providers, et cetera. If we start to see these little changes, and suddenly a woman's coming in, oh my gosh, 4 times this year for a UTI. I mean, okay, a urinary tract infection that's happened 4 times in 1 year, and this woman's never been in for a UTI before for 5 or 10 years, and suddenly we see that level of change, and that should be like a ding ding, right? Like, hey, here we go. Hey, this is not this woman's normal trajectory, right? Or a woman suddenly has an increase in back pain and like her legs feel heavy and dense all the time, and she feels like she's trudging up a hill just when she's walking in her house. You're like, okay, hold the door. What is going on in her system that suddenly she didn't feel like that last year, but now she feels like that this year? And you start thinking about pelvic congestion issues, and like, what's her vascular health doing? And I think this is the stuff that women are being pushed around about. I don't know how else to say it, because by the time they enter my clinic, they've been fooling around with symptomology patterns, as you say. And think of it, if they've had pain for a period of time, that low level kind of, just nagging agitation, think of how it changes their brain, changes their mental health, changes their outlook and their status just on life in general. And I think these are the things, if they feel it, they need to have people that they know I can go to, and they're going to listen to me and help me process, how do I walk through this time frame?
Right. Right. Yeah. And pelvic congestion, it's funny that you mentioned that. That's one that, oh, that happens, during pregnancy, a little after pregnancy, and, all the venous congestion syndromes together, because there are actually quite a number, are something that I find is not so much. And they're finally, now that they've imaging showing it's not so much just, someone who's in their 20s or 30s. There are a lot of women in particular who walk around and they're in their
Absolutely.
50s and their 60s and their 70s.
Absolutely.
And now the problem's so chronic that the treatments that they're developing, which have been phenomenal, are still not good enough. And those women still are kind of
Mhm.
like, well, okay, you didn't do well with that. We don't know what else to do with you, right? If only that was recognized earlier, these women could have gotten that care
Mhm.
earlier. And that, that dovetails
Mhm.
with menopause and their transitions and just saying, well, okay, you know, that's what we expect you to go through, and just kind of suck it up, take a breath. And then you wonder why anxiety and depression increase during this time frame when no one's listening. No one's listening. So how
Mhm.
frustrated can someone be? And that,
Mhm.
even increases pain, sensitivity to pain. So we're talking about a huge cycle
Mhm.
that's being created because these conditions are not being paid attention to, especially in the pelvic health world, where they're embarrassed to step
Mhm.
forward and say, I've got incontinence or constipation. They thought, well, that's just a slow colon. Well, no, there's a lot more to it than a slow colon, right?
Absolutely.
That's just one part. So you're so right when you say that we really need to look at these and just see some little flags that come up and say, wow, wait a minute, all of a sudden X, Y, and Z is happening. Maybe there's a little more to it than just what's on the surface, right?
Yes, I mean, and I think if you look, I mean, I'm sharing this with, companies right now. I want companies to realize, like, the data basically said the health economics impact 1.8 billion lost in revenue. 1.8 billion. And think of it, if we're talking about these women, they're from age 45 to just 64 years old. We're not even talking about, even longer life, but they're in the workforce, right? And they're trying to work every day and they do not feel well. And they are so pushed off, like, and so not taken care of that, it almost makes a woman's life kind of close down and get smaller and smaller because they just never feel very good every day. So I guess this is what I think, as in the big picture, we need to start looking at, our own organizations, whether they're PT organizations or whatever. But in the bigger picture, right, medical community itself, but then also in our big corporations, right, and say, hey, what are we doing to look at women during this age pocket, and how do we take care of them so that they have a support system inside the corporations, inside their own communities? I mean, it's sort of what we're doing introspectively in our own organization right now, is saying, hey, how do we care for women in different sections of their life? They need different things. We don't want them just to leave our workforce, right? Because we can't figure out how to provide the right setup for them.
Yeah, yeah. I believe, if you add medical costs to that figure, I think it's something like 2.3 billion in lost, right? So think about it like, hey, folks, if we can take care of people earlier and we can recognize things earlier, isn't that a huge cost savings, kind of thing to not just the individual,
Mm,
also to the company, to the government, to the,
yeah.
you name it, right? It's a win-win for everybody. And that's kind of what I've really, really tried to push is like, let's educate. Educate is the way to change. That's why I'm so thrilled about being able to talk to you today because I feel
Mhm,
like if we can just get a few people more to realize, wait a minute, as an individual, I can do something. Whether I'm a PT and I know go to my family
mhm,
med,
mhm,
practitioners who refer, and I have an in service with them. Whether I talk to other PTs, whether I go out, I do a lot of stuff with the American Urogynecological Society every year. I actually
mhm,
teach the nurses. I've done doctors and nurses, but each year at the APP conference, I teach them how to do a musculoskeletal assessment. They don't learn
mhm,
that. They have no idea
mhm,
what a musculoskeletal assessment is. And they come up to me afterwards and they're
mhm,
like, Ingrid, you blew my mind. You just totally changed my practice patterns. I didn't know what I could find. I didn't know
mhm,
how I could refer. I didn't know what I was missing. Right. So, anyway, as an individual, we do have the strength and the power to make these changes. I think we just need that education ourselves to learn a little bit and then
mhm,
step forward and do that education, pay it forward, so to speak, educate others, right? And again, hating to go back to the book, but that is my goal is how much can I educate? How can I change people's minds? How can I get people help
mhm,
earlier? That is just like the bottom line. Everything I think at the root of what we're talking about is educating and getting people to understand how important it is to understand the interconnectedness of our body, our pelvic floor to our core to the rest of our body, mental health, all of that. And then how we work as a
mhm,
team, all of that just comes together. And once you
mhm.
experience it, it resonates. And then it's like, wow, let's tell people about this, right?
I want to share this too because I think sometimes people don't really understand, like, well, why is a women's health physical therapist or occupational therapist part of this team, part of this continuum of care? Because I think, we have to help communities understand, like in the physical realm, if the body doesn't feel good musculoskeletally, it affects the brain. It affects the ability for us to work and function at our highest level and do the best with our gifting, right? So, who are the prime people that we're talking about? We're talking about the people who know musculoskeletal work probably better than anybody else, right? And that is the physical therapist in particular. Do you know what I mean? From that whole postural positioning, from that whole, kinematics and kinesiology and all of that, right? And that's why I'm saying that there cannot be a continuum of care that does not include the physical therapy realm. So for us as therapists to think that somehow or another we're not going to have anything to do with women for 50% of their life, it's a crazy thought that and I think this is why, like, when I think through even, people who say, well, I'm never treating the pelvic floor, I'm never treating pelvic health, I'm never touching anybody who, we're not asking you to do that. We're asking you to have the vision to understand how all of this integrates so well. So if you have a back pain patient or SI joint patient or a hip patient or things that don't make sense to you from an orthopedic realm as a physical therapist, hey, we're part of your team. We're part of all of this. So I think us going out into the world in general, like you're already doing, talking to different people all about the work that we do, right? So we're not only educating inside our own system, but we're out in the other world. But we also need to educate inside our own system to be able to say, hey, these aren't separate things that you separate out from each other. These are all integrative work that we should all be doing together. And you can't tell patients, and don't get me wrong, I get people who say, oh, we went to this person, I went to that. And no, this has to become such common knowledge, right? That it's that integrated down to our level in the PT world, but then also out into the next levels of, our providers and the community so they know, oh, I have an issue going on where I've been constipated now 5 times this year for 5 days each. Huh. Like that's a problem. And that was
Right.
never before that I reached the age of like 45, right? Like, so something's changing in your body, and you have to understand that there's people who know what to do to help you with it, right?
Yeah. Oh my gosh. Yeah. It's interesting. So I think my first foray into teaching others about what we do was my fellow PTs within a clinic. So I was always like the women's health therapist, and then the rest were mostly orthopedic, and sometimes they were cardiopulmonary or other specialties as well. And I thought to myself, well, they would come and ask me a question kind of on the sly, and like, Ingrid, my patient's having this, and so I'm like, hmm. And they got more comfortable asking me questions. I'm like, how about I do an in service? So I did an in service for our clinic. And then, so being Duke, because it's a huge system, it was kind of like, well, why don't I do an in service for? Why don't I do a grand rounds? Wait a minute, OBGYN, why don't I do your grand rounds? And it just kind of what it did is it grew from I'm going to have a small group and the discussion. And believe me, so I'm not the kind of person that normally would be very comfortable standing up in front of people talking. But when I get into this topic, I'm like, I've got to just get this out. So what happened is I got so used to talking about, so many different topics of pelvic health that it became perfectly normal and comfortable for me to do that. And then I realized how people afterwards would come up to me and say, I didn't know about that. I had no idea. I didn't know that that would happen. I didn't know I could do that. I didn't know I could recognize it. And so the next step I took was, so when I ask my patients and I do my intake, I do my subjective, I ask about every component. So if they come to me for incontinence, I'm still going to ask them about sexual issues. I'm still going to ask them about bowel issues. We all do that. And then I thought, well, shouldn't everybody really be doing that? So now when I talk to other groups, I always have a couple slides on, if you're not comfortable verbally getting it out, put out a questionnaire that the patient fills out before they start with you. So, even athletic trainers, hey, ask the questions. Your female athletes actually are at high risk to having incontinence and sexual dysfunction and other problems. Get comfortable asking it. And then I give examples of what are the questions you can ask, right? How do you get comfortable asking? How do you get comfortable practicing it so that eventually it isn't such a barrier? Because I could see that other practitioners might say, I am just not comfortable talking about that. But there are ways to talk about it that can make people perfectly comfortable. And now all of a sudden, all this information comes out, and they discover that patients like, I'm so glad you asked me that. Nobody has ever talked to me about that before, right? That's what I get as a pelvic PT all the time. We get that as pelvic PTs. It's like nobody even bothered to ask me that if I was having that problem. Well, in this transition, this whole continuum of life, isn't it important to ask those questions so we can capture that information and say, I think maybe this is who you need to see. I think this would be helpful for the symptoms you're having, right? So, I'm so loving that you said that, like that whole, how do we educate and how do we bring up this subject and how do we talk about it? How do we get other practitioners to talk about it? How do we talk to other practitioners? Well, the more we do it, the more comfortable we are doing it, is what I will say. I don't, like I said, I was not, it was very difficult for me when I started. I'm very much an introvert. I don't normally just love getting up in front and talking to people, but when you become very passionate about something, you throw that aside and you realize how important the topic is. So that's what I'll say to, people listening, is encouraging them just to start small. Start with a little group, people and then grow it and build it. It will happen.
And I want to encourage people who are listening that aren't even medical professionals. Like, if you've had an interaction or you've had issues and you had resolution by attending PT, or like having or being connected with somebody who actually taught you something about the way your body works during these different transitional time frames in your life, talking to your friends about it. Like, if you have painful sex, probably one or two or three of your other friends has it as well. And everybody's quiet and mute, right? And not talking. So everyone feels alone in it. One night I was at a huge dinner group with a group of very artistic people. And literally at my end of the table, suddenly somebody asked some tiny little question because they knew what I did. And pretty soon the whole table is literally talking about sexual health. And they're like,
I
"We
love
didn't
it.
know that. Oh, tell me this. Oh, tell me that." You know what I mean? And now those people, right? This is what's happening, right? They are going out into the world. They're not medical people. They're artisans, right? They're going out and into the world and saying to other people, "Oh no, you don't have to live with that. No, no, this is not okay.
Awesome.
Hey, there's things that you can do for X, Y, and Z." And I think this is the beauty of like us as practitioners, but even other people who are not, using your voice to support other women so they are not alone in this, so that they're not quieted down. We culturally sometimes have different, groups of people who are maybe quieter about things, but it's interesting how, we had a, a Catholic group in our region, one of the main ladies reach out and say, "Hey, I want to understand some things so that I can help our whole, a religious body with these things because these are very important to us." And so we, talked through things in a way that would then work for them to have conversations, not with me, but with each other about the things that I had taught and educated them on. So I think this is the beauty, right, of us saying, "Hey, we're no longer going to be quiet about all this information. We have to find our voice and we have to help people understand like these are normal functions, bowel, bladder, and sexual health. They keep us well long term, they give us longevity, right? And we need to honor them inside of ourselves, right? And then say, okay, how are we going to do it?" So I love what you're talking about. I mean, we have to keep having these conversations because the more we do talk about it, and like you said, you were an introvert, and I wouldn't know that now when you and I talk all the time about in our conversation.
Oh, yeah, that's what everybody says. An introvert generally is someone who, they're not antisocial, they are more, um at the end of the day, they feel drained. Their energy is
Mhm.
kinda out and they need to rejuvenate, whereas an extrovert's kinda like, "Yeah, bring it on," and they grow from that energy. So I'm somewhat shy, but, I like I said, I overcame it because I feel like this education like, I got over myself.
Mhm.
How else can I say it? I got over
There you go.
myself. And I said, it's time to really educate and help people." And I think that has changed the way I can present, I can do things. I will say for those of
Mhm.
you out there who are like me, oh my gosh, I have to think. So I was invited to do a presentation for a group here that does all interdisciplinary medical care for the state. And I had no idea what I was getting into. But they said, can you please talk about sexual dysfunction? I'm like, sure. So the doctor and I shared this 1 hour time frame. And I typically reach out maybe, I don't know, a week or so before, and I'm just like, hey, so what does the room look like? And, how many people do we expect and that kind of thing. And she goes, oh, yeah, yeah, yeah. So we're in the ballroom of this hotel and we have 300 people already. There's going to be standing room only. And I'm like, so I have to talk about sexual dysfunction in front of 300 plus people. But what I did when I got there, I did my superwoman pose. Took a couple diaphragmatic breaths. They s were s all the IT stuff was screwed up. They didn't have my name down, everything, it was like a mess, and I kinda just laughed and I said, "So this is typical me, and you're gonna roll with it, right?" So what I did is I talked
Mm.
to individual people in the audience as if I was talking one-on-one, just like we're doing now. So I'd look at them, and then I'd look at someone else, and the funny thing is I found people responding very positive. You could see them, like, nod
Mhm.
when I looked at them, and I thought,
Absolutely.
so I'm just going to talk to one person at a time in this room instead of 300. And that helped me through. And ever since then, I've been like, it doesn't matter the size of the audience. Just
Mhm.
know you're talking to people and you're reaching out to them and hopefully changing the way they think.
Absolutely.
And that made such a
Mhm.
difference for me. I know that's a little off topic of our pelvic health
It's
world, but
okay.
for those of you who want to talk, who want to get out there, just think about that. Know that, hey, I've done it. I'm not special. You can do it too.
Mhm. Mhm. Absolutely. Thank you. I think that's so important because I think people get afraid, like to know how to present or how to say or what they should be doing. So that really that hits home, right? We're just one person talking to another person sharing that information, right? So I'm gonna just bring up something because I know you just saw the movie The M Factor. Will you share a little bit about the M Factor? Some people know it, some people don't. Just give your take on it because it's definitely a component of education, and it's been great that it's kind of been laid out there the way it has.
Yeah, so first I'll say I'm very happy that this information is getting out to people. It is good that people realize that the world of hormonal treatment has changed, the world of understanding menopause is changing, that we're
Hmm.
doing more research into it, that it's great that people do get this information. I would say so I've seen it twice. Once I was in the audience and once I was on the panel. So the cool thing is they have the panel discussions afterwards where I think people really feel like they are more
Hmm.
comfortable opening up and asking questions. So the on the first one when I was in the audience, the questions were one after the other about hormones. Hormones
Hmm.
this, hormones that, estrogen, progesterone, testosterone, all of that. And at one point, one of the panelists said, "Well, we need to look at doing um, a coordinated team, to treat these patients." And I just couldn't help myself. My hand went flying up in the audience, and I'm like, "I'm so glad you talked about a team." And I went into the whole conversation we just had about teamwork and how important it is for everybody
Hmm.
to realize that quite often we can't treat these things with one practitioner, but we need help from all different
Absolutely.
components. So it was really good because people afterwards came up to me, even though I wasn't on the panel, and started asking me questions because they wanted to know more about what I was talking about. When I was
Hmm.
on the panel, what was really cool is the vast majority were physicians. I think one was a nurse, one was nutrition, and then I was the only PT on there. So I thought, well, let's see how this goes. And of course, all the questions just started all about estrogen all over again. But now, because I was on the panel, I had the opportunity to weave pelvic health in there. And I said to them, looking up, and this was probably there were probably about 130 women come at this M Factor showing. And, I looked up in this big amphitheater to them and I said, so, look around you. Between 1 in 3 and 1 in 4 of you have a pelvic floor disorder. Yet, do you discuss that with your neighbor, with your friend, your loved one? Have you talked about these things, right? I said, this is how common these issues are. And it's not just necessarily that our hormones and taking replacement therapy can help you. Yes, they may be able to. Maybe you don't want to take them. Maybe because of other risk factors, it is not appropriate for you. What we should be talking more about, what is okay for the individual. We want the treatment based on the
Hmm.
individual. And I said, if you come to PT to, let's say, resolve incontinence, that doesn't mean you can't go on hormones. It doesn't mean that these all have to be
Hmm.
separate entities. They can be one layered on top of the other, whatever is right for you as an individual. And the look on people's faces was kind of like, oh, oh, we didn't even think
Hmm.
about it. So I said, look, we should be talking about urinary incontinence and constipation and pelvic pain and prolapse. We should be happy to say, hey, this is what's going on. And if you need help, I know where you can go, whether you're a practitioner or not, because this was a very mixed audience that was listening. And it was really cool. And I mentioned I have a nutritionist sitting next to me. There are times where I say, well, I can maybe offer a couple things to help you on the right track. But here, this nutritionist is going to be the one that will help you sort through all these questions and get you in the right direction with that. You may need the physician to help you with the hormonal part. You may need someone else to help you with the overall health, with the cardiovascular, right? So looking at this team, and I talked a lot about team while I was up there. And I think that resonated with people is that, hopefully enough of these M Factor viewings have a multidisciplinary panel, not just, oh, we're going to go from the lens of hormones. Because I think we're shortchanging our folks when we just say, let's talk about hormones. And yes, the whole Women's Health Initiative, that whole study it was not looked at properly. The data was not interpreted properly. Let's not just harp on that. Let's harp on all these other things that we
Yeah.
can help our women with through their life, starting earlier than menopause, right? We're waiting too long when we're already in menopause. So I think that resonated. So my take is I'm just hoping that out there in the world, when people are viewing this and they go to the showings, that there's a multi or interdisciplinary panel that's talking about all the different ways that women can get help.
Absolutely, because I think there's just so many care gaps, right? I think some of the data was like 60% of all women with moderate to severe menopausal symptoms do not receive treatment, even though they have insurance coverage that would actually cover it. And when you look at that, I think that's this interdisciplinary thing. And when you realize is that, only 20% of all the OBGYN programs even have menopause training as a formal training. And you think, well, no wonder people get frustrated or get, feeling like, oh, I don't know what to do. And I think that's why this whole thing at least is getting us talking about all of it, right? In a really, like a big way, even if we don't have all the answers yet. I think that was the next thing when we're looking at these care gaps. Maybe share with me some of your ideas of like, you mentioned education. I think that's a huge, component of it. But are there other things that you think of maybe we all should be working on together, to really make a change for women during this 50%, 40 to 50% of their lifetime?
Yes, I would say I have to say education is the key because if you think about it, if we just don't know what we don't know, we'll never ask
Mhm,
for what's appropriate for us, right? And that doesn't
mhm,
matter whether you're the practitioner or the patient. It has to be coming from both sides because the practitioner may know a little bit, but that if the patient's not receptive because this is so freaky to them, then they may not follow
mhm,
it. So I'll give you an example in the Urogyn world where that is what they treat. This is the pelvic floor that they work on. Less than 50% of the patients who are referred to pelvic PT actually go. And I think that's the
wow.
barrier. Oh, I
Mm,
I I think the barrier is education because if that Euroguide says, "Yeah, you should go to pelvic PT," but they don't say, "Because of X, Y, and Z, this is what you might get." We don't reduce those fears like I talked about way in the beginning of, "I'm afraid of you."
right.
Right? So if someone's afraid of something, what is the chance they're gonna go? So there's this huge barrier going on that we could change very easily by having, the practitioner understand better what we do as pelvic PTs, and we as pelvic PTs understand better what they do. And I shadowed with doctors, PAs, nurses, whatever, and I found I got such amazing information from that. So that's like that big world is education on all ends. The other is to, once you get more comfortable talking about the topics, is to reach out and say to our whether it's locally or federally, it doesn't matter, to say, hey, this is the data. Like you've been talking a lot about data. We have more data now. So I just wrote to our state, excuse me, our federal um, US senator yesterday about like my experience as a pelvic PT and then, some of the data, some of what we've been talking about and why it's important that research right now needs to be funded for this
Mhm,
so that we get that care earlier. So as an individual, you can write letters to your senators, your congressmen. There's nothing wrong. You can ask for an audience. People feel like they can't. They actually can. I've only learned this more recently about advocacy.
mhm,
So advocacy is the
mhm,
other branch of what we're talking about. Education comes first, then you can advocate. So if you've that basic knowledge, then advocacy, and that advocacy can be on an individual level, talking to your loved ones, to your friends, that kind of stuff. The advocacy can be, I can now educate. The advocacy can be to our government. So it's really a combination of that education first, advocacy second, when you feel like you're a little bit you have more knowledge and you're able to talk about these things in depth enough to change people's minds. And that's kind of what we're doing too is just change. Oh, I didn't realize how common these problems are. I didn't realize how people feel they're alone. I didn't realize that we don't have dollars funded towards research. You know what I'm saying? So
mhm,
once you know that, I think then that advocacy arm of it becomes extremely important. And don't worry if you don't feel like you can do it today or tomorrow. Build your knowledge base, build what you understand, build what you know, build your experience, and then start the advocacy component of it. So, I was trying to think when you were saying that because education always is paramount in my mind, but I think advocacy
Mhm.
is how we now take our education and make a difference. This is what we're doing now is advocacy because we're empowering people to say, whoa, wait a minute. I can do something as a practitioner. I can do something as a layperson. I can do something as a patient, right? Now I take it a step further and advocate for others.
So, do you think that this could be considered a pelvic health crisis, that we really have not done a good job? Do you know what I mean? For women in this time frame, is that a component that you feel like, wow, this has like been so not talked about or mismanaged or misunderstood or no research has been? Do we look at it as a possible pelvic health, a public health crisis?
Mm. So I guess I'm trying to think how I would word that. So, 10 and 20 years ago, when I felt like I was the only one, it was a crisis because it was like, how do I get the people to me and how do I treat them? What I'm thrilled about is there are more practitioners. There is an improvement. But unfortunately, I have to say it probably is still a crisis just because we're not far enough yet. We don't have enough people understanding. We still have people thinking we don't want to talk about that topic. And it's every age group. It's not, people like to say, oh, that's just like baby boomers or that's older people or whatever. No, it's every age. Oh my gosh. Stop with the generation stuff. I've said that before, even on LinkedIn. It's like, no, 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 no. We all learn from each other, and it can continue to be a crisis when we just say, "Well, only our generation is going to take care of it," or "It's your fault," or for anything, it's your fault. No, 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 no. Let's take this into our hands, learn more, and do more. So yeah, it's a bit of a crisis because I feel like unfortunately pelvic health is still way down here not looked at, and people still feel like it's a taboo topic, which makes me so sad that it's a taboo topic. These aren't taboos, they're just things that people have been taught to be embarrassed about. I don't know how else to put that. That we need to change that whole notion that this is an embarrassing topic, that this is something that happens to so many people. And boy, we need to step up to the plate and make sure people get treated for it and taken care of and prevented. Something that we don't do enough in medicine. Let's prevent the problems, right? And that's what pelvic PTs really do.
Mhm. Yeah, and I think when we look at these care gaps, you look at it, I love what you already said, education. So, medical education reform, pelvic health campaigns, insurance policy changes, research investment, right? Creation of more menopause clinics, specialists, I think education in schools and workplaces. I think all of these things, right? And they all encompass around education, they all encompass around advocacy, which you just talked about. But I do think that if you look at long-term life and long-term longevity, I mean, look at women, women who have, a history of UTIs actually get put in nursing homes faster than any other woman, and the quality of life declines. Same thing with bowel issues, bowel constipation, bowel fecal leakage, all of those things that what no one wants to care for them, so then where do they get put? Somewhere outside of their community and their support system, right, away from that, and that destroys longevity of our communities, right, because pelvic health things are not being addressed. And I honestly feel like, now knowing the depth of what we know, knowing we don't have enough research data, knowing all these things, but you and I seeing it and the practical thing every day when we're treating patients, right? We know these things are affecting long term quality of life, the pelvic health issues. So you and I have no choice, and we will continue to drive this ship forward and fight for, right, like everyone to have the understanding of that these are quality of life issues long term, and they actually promote longevity. Whether it's a woman in sport, I have women in sports who literally have a leaky bladder. So they don't like that, right? And so then they tend to do what? Shift away from the level of where they actually could excel, right? So it's affecting women and men across their lifespan, not just, in the continuum, as you and I were talking about before. And I think that's why, it is a public health crisis in a way, because we're not really stepping out, bold enough to say, hey, this is not something that we're sweeping under the rug anymore. Like,
Right.
this is literally going to change people's lives for the long term. And it's so much why I wanted to talk to you today, because I appreciate your drive in education and advocacy. And I appreciate that you just don't stop with it. You just keep pushing forward. I mean, it would be easy, for the stage that we've worked in this field, for me as well, over 40 years, to say, oh, well, we can just be done and hand that over to somebody else. Right. But like, I think our heart is for the people who don't know, don't understand. And we know that we need to make a change, and we need everybody's voices who works in this arena to be able to do that.
Oh my gosh, yeah. I I feel like I don't know if I'd ever stop doing this. I just enjoy being able to make those changes, right? But I also like to see, and I encourage all those, who've come after us, to please step up. Please, I know there are different parts of your life where you may not feel ready for it, but when you do, please, and keep that knowledge in the back, and keep working on it, and keep developing it until you become more confident in doing it. And I
Mhm,
can encourage all those who come those years behind. That's what I'm saying. Like, I stand on the shoulders of those who were struggling and
mhm,
yelling and screaming about before and not heard. And I felt in the beginning I was not heard, and I was yelling and screaming, and maybe a little bit heard now. So maybe the next level heard even more, right? So, don't give up.
mhm,
Even when there are times where you feel like no one is listening. Don't give up,
mhm,
because the more you do it, the more people will listen. And the more you reach out and you get to meet lovely people like you, and really have great, great conversations, right? And really, hopefully when people hear that, it's like,
mhm,
oh, I can do that. I will do that.
mhm,
And it's important to do it. I think our
mhm,
discussion has kind of let people realize how important this really is. It is something we have to fight for. And that's why I was okay with using the word crisis, because I think that lets people realize I need to fight for that, right? I need to work for that,
Absolutely.
and make the change,
Absolutely.
right? And that's what we're here to do.
I love it. Well, Ingrid, thank you so much for your time today. I know you're such a busy woman, and I appreciate you so much. And it's been such a pleasure to get to know you. And it really gives me encouragement as we move forward to, to work together, to collaborate, to figure out how we get out there in the world to really make a difference with all this. So thank you again for your time. And everybody, Ingrid's on LinkedIn. It's a great place to find her. She is an amazing resource. She's been doing this work for so long, and her work at Duke, and just the fact that, she wrote this book, and she's so dedicated to really helping people advance, in our field, but not only in our field, but outside of it, in all the medical fields as well. So again, Ingrid, thanks. And I know you and I'll be talking again.
Thank you for having me. It's such a pleasure to be on, and thank you for all the work you do.
Oh, thank you, Ingrid.